share my. Right, I hope you can see my my presentation. So I've been a stroke physician for the last 6 or 7 years in Southampton, and 2 or 3 years ago we were invited to become a hyperacute stroke research centre, and this is a initiative that's been set up by the NIHR with the idea that within tertiary neurosciences centres we have the infrastructure and the ability to do some quite advanced stroke research using imaging, MRI scans, some of the techniques that we can use in terms of trying to treat acute stroke. So we've now got a number of devices that we can use to remove blood clots from within the brain quite quickly. But the whole idea was that you randomize patients into trials within 9 hours of their symptoms coming on. So it's been quite a challenge trying to put into place the staffing and infrastructure to make that happen. We are operating on a 5-day week at the moment within working hours, but the aspiration is that we will expand out to cover evenings and eventually 7 days a week, so that patients that present with strokes can be recruited into trials, usually within the first few hours of them arriving in hospital. And this requires complex interventions, so it needs to be done quite quickly. So there's a variety of different treatments that we use. There's clot busting treatment, thrombolysis. There are new drugs coming on stream for that. There are various drugs used to protect the brain when someone has a stroke to try and limit nerve damage. And there are various devices that are being used to try and remove clots from the brain or remove bleeding into the brain. And so it's a real opportunity to work with our colleagues in neurosurgery and also neurointensive care to try and improve outcomes for our patients. It does require fairly complex interventions. So we have a number of different imaging things that we need to do. So angiograms to look and see whether there are blocked blood vessels. Perfusion scanning basically tells us whether there's an area of damage which is permanent or whether there's transient damage, and opening up an artery is beneficial. So it tells us whether there's it's worthwhile intervening. If you have a big stroke and a blocked blood vessel, a perfusion scan will tell you whether there's a core area of damage and just quite how big that is. And by doing this, it means we can now treat some patients up to 24 hours after the onset of their symptoms. So it's expanding the time windows of what we used to be able to do historically. And some patients undergo surgery following their stroke, particularly patients that have had a big bleed into the brain, or they may well have had a large blockage of a blood vessel and develop swelling, which means they need neurosurgery. And again, there's a number of trials that we're looking at. There's one trial which we're going to be doing, which looks at reducing edema and swelling around patients that have had a big stroke, and hopefully will reduce the need for them to have surgery if it turns out to be a positive trial. And so the way that the stroke service works in Southampton, we've got 14 beds. We've had 3,000 referrals. We have about 1,000 patients who come in a year. And we've had 130 patients treated with thrombolysis. So this is clot busting treatment for patients with an ischemic stroke or blocked blood vessel. And 112 patients we've treated with mechanical thrombectomy. So I've got a video to show you how that works. And why do we really want to focus on hyperacute studies so early on? Well, really, we know that if you open up an artery quickly, you're more likely to restore blood flow to the damaged area. And this is a time-dependent process. So the faster you open up a blocked or occluded artery, the better the outcomes. You limit neuronal damage and improve neurological disability and outcomes for patients. As far as bleeding into the brain is concerned, we know that if you try and limit the size of the bleed, and we know that blood pressure lowering can do that, that reduces the size of the hemorrhage and again improves clinical outcomes. But the outcomes are much better if you do this within the first 2 or 3 hours of patients presenting, rather than if you do it 6 to 8 hours, as it were. So this is my stroke nurse practitioner team, and what we're doing is we're working alongside the stroke research nurses from R&D. So this is the team that provides 24/7 cover in Southampton, and we take referrals from across the Wessex region. And the idea is that alongside our research team, they're being trained up with GCP training, but also with information about the trials. And we've actually run simulation training days with the nurse practitioners. So we have a mannequin that we start in the A&E department, and we create a trial scenario whereby someone could be potentially randomized into a study. And then we go through the process of doing mock consent and actually drawing up the investigational product or the medicine that we're testing, so that when we have real patients, they have some experience about how the randomization process works. So just to explain the main stroke subtypes that people can experience. So ischemic stroke, that's 80% of cases, and that's due to a blocked artery, due to a blood clot. And depending on where that blood clot is, will depend on what sort of treatment patients will be eligible for. So if there's a small clot further down the artery, so if you think of it in terms of the arteries being rather like a tree with a trunk with main feeder branches going down to twigs at the end of the tree, as it were, the further down the tree the clot is, the more difficult it is to treat in terms of extracting it, but we can give clot busting treatment or medicine to try and dissolve the clot. And that accounts for about 80% of cases of ischemic stroke. Hemorrhagic stroke is 20%, and that's where there's a rupture of an artery, often due to atherosclerosis or furring up of the blood vessels. And these are time critical processes. So as soon as a patient comes into A&E, we get a pre-alert from the ambulance crew that the patient is on its way in. So we meet the patient with the research team at the front door. As soon as they arrive in hospital, we take them around to the CT scanner. We aim to get a scan done within 10 to 15 minutes of them arriving. And then if they're going to be enrolled into a clinical trial, we quickly go through the eligibility criteria. And the idea is that we want to try and get thrombolysis treatment on board or clot busting treatment on board within 60 minutes of them arriving in hospital. And there's no doubt that the faster you deliver this treatment, or the lower what's called DTN or door to needle time, the better the outcomes for patients. And we use CT angiography routinely now to identify blocked blood vessels. So here are some examples of brain scans with CT angiograms. And at the bottom left there, you can see there's a 3D image now. So the imaging has become really quite advanced in helping us identify exactly where the occluded or blocked blood vessel is, and then whether we can either treat it with clot busting treatment, thrombolysis, or extraction through mechanical thrombectomy. So this is a video about how the thrombolysis process works. I hope it plays okay.
So when we were developing our thrombolysis pathway, the crucial thing was to determine what are the things that we actually need to do to deliver this treatment safely and eliminate everything else from the pathway. The first thing we did was we arranged for the switchboard to be able to put out a special bleep call for the stroke team, which says blue call for stroke team, estimated arrival time, and then however minutes it's going to be. And the team then prepare and go down to A&E to meet the ambulance as they come in the front door. Our core stroke team is a band 6 nurse and one of our clinical fellows, who are usually at senior house officer grade, so they're not specialist registrars. They will then wait by the front door, they check over the equipment, make sure everything is ready to receive the patient. And when the patient comes in with the ambulance, they take them straight away to one of our resuscitation bays, which is fully equipped for dealing with strokes. One of the ambulance staff then has to go immediately and register the patient on the hospital system so that we can request blood tests and scans for them. The other ambulance member of staff then hands over the details of that patient's presentation to the stroke team. Once we've got the history from the ambulance staff, we then take the history from the patient. Now, the crucial thing is that when somebody comes in with a stroke, what you actually want is to be able to take a history from the patient or from their family as to what's happened, and to do a comprehensive neurological examination to determine whether they've actually had a stroke. And at the end of that time, the diagnosis of stroke should be clear, should be yes or no. So we'll then place a cannula in one arm, we take a blood sample, we don't usually wait for the results of the blood test, but we always check a blood sugar first. And if the patient is on warfarin, we will always do a local patient testing INR test, which is the test you do for warfarin, to make sure that the patient is safe to thrombolyse. The next crucial step is to get a CT scan, because the CT scan will rule out hemorrhage, which is a contraindication of thrombolysis, any other diagnoses that we haven't thought of, like brain tumours, and also we'll look to see whether there are signs that this might be a very large stroke, because in a very large stroke, thrombolysis can also be dangerous. As soon as the scan is on the screen and the radiologist has reported the scan, we'll then communicate with the consultant and say, look, this is the patient, this is their medical history, this is what we find on examination. We've gone through the lists of contraindications to thrombolysis. Here's the scan report. This is what we're seeing on the scan. And the consultant can then make a decision, usually in a few minutes, by asking one or two questions to clarify various points that they're unsure about. The correct dose of drug is then drawn up, subject to all the forms being correctly filled in, and the consultant giving the say-so. We then give that bolus injection, which is the start of the treatment. As soon as that bolus injection is given, the nurse will make up the rest of the dose, which is given as an infusion over an hour. Once the infusion has started and the patient is stable, we then try and take them up to the ward as quickly as possible. Then they go onto a cardiac monitor and they're monitored with a careful protocol of blood pressure, pulse, and temperature and observations for the next 24 hours.
So that's how thrombolysis works. So I can just advance the screen. And this is how mechanical thrombectomy works. So this is the relatively new treatment that's come in over the last 2 or 3 years. As I say, we've done about 100 cases so far this year for really big clots.
Mechanical thrombectomy is used when patients come in with typical stroke symptoms. Some of those strokes are caused by blood clots in smaller blood vessels, and some of them are caused by blood clots in larger blood vessels. And if the blood vessels that are affected are larger in size, meaning a couple of millimeters in diameter, then these patients may qualify for mechanical thrombectomy. It's minimally invasive. Endovascular procedure, which means that we go through the groin blood vessels and then advance small catheters all the way up to the neck vessels, eventually to the brain. Through those catheters, we can use several different types of devices to remove blood clots from the brain. Basically, we're pulling blood clots out of the brain with the help of our catheters and endovascular tools. Recovery is not really dependent on the procedure itself. Once we remove our catheters, the hole seals up within a few hours. It depends on how severe the stroke symptoms were or how severe the stroke was, and the recovery in an optimal case, if the procedure goes well and there's no significant brain damage, then yes, we've seen patients walking the next day after a stroke. If there is more damage, then it could take a couple of days and even rehabilitation stay first. We have a system that all of our patients are followed, usually 2 to 4 week time window after discharge from the hospital when we see them in clinic. Evaluate them, make sure their workup has been completed for the stroke, they are on the right medications to prevent further strokes. The patient is not taken care of by one person when they arrive to the Cleveland Clinic, but a whole team. Nurses, ED physicians, neurologists, endovascular specialists are all trained to deal with these situations.
So that explains how thrombectomy works. So how's our PPI group going? Well, we've had our first meeting a month ago. We've had former patients that have been enrolled in clinical trials and also some patients from different strokes. So that's a local support organisation for stroke victims, and we've constructed an agenda and have been quite looked at the clinical trials we've got on our portfolio at the moment. And I think one of the things that has emerged is about communication for patients. So quite a lot of stroke patients will have dysphagia or problems with their speech when they come in and understanding. And actually, can we make the consent process simpler? Can we provide pictorial diagrams? Can we provide videos? Can we provide simplified consent forms so that we can communicate what the trials are about in as simple and as effective a way as possible without overburdening people with large amounts of information. And one of the problems is, or challenges, I guess, is that getting people into these trials quickly, because we want to start these treatments as early as possible, can be quite challenging. And we often have to involve carers and people supporting the patient in the decision making as to whether we're going to randomize them into the trial. So, but we've got 3 big studies on the portfolio at the moment, including a thrombolysis trial. So the injection or infusion that you saw in the video, that uses a drug called alteplase, but there's a newer agent called tenecteplase that is undergoing a study at the moment, which is just a single injection. And the advantage of this is it could be given in the back of an ambulance or in the A&E department. It's much simpler and quicker to give, and you're not relying on an infusion over an hour in order to treat the patient, which then obviously requires a lot more monitoring. You just give the single injection and then the drug is delivered and it's done. And it should mean that the treatment times are faster still. So we've got that. We've got some imaging studies coming on, so using advanced MRI scanning to try and improve stroke outcomes, identify which patients are going to benefit from treatments. For big strokes, we've got a study looking at reducing edema or swelling around the stroke to try and prevent the need for them having surgery. So there's lots of exciting things going on. So I'd be very grateful for any thoughts or questions or ideas that you might have as a group as to how we can potentially take things forward. We're going to meet every 3 months or so. We're thinking about widening participation and ensuring that we get equity of access to all the patients that come in. And what is it that most matters to our patients and involving them in the research studies. I think that the key thing is not only communicating what the trial is about, but also about the outcomes as well. So when the studies are published, that we feed back to people that the information that their participation has made a real difference in changing the science and the knowledge and the way in which we treat our patients. So I think that's probably all I've got to say, but very happy to field any questions or talk things through if anybody's got any thoughts.
Let me stop recording first.